dental filling. We have had several fillings that has been tried to restore the tooth from the context of filling and bringing back the tooth to its function. We have historically used many metals, including gold, silver, and many other alloys. But over the period, what we have understood is the tooth is not made for a metal. From that context, the dentistry has invented newer materials which are more tissue friendly as well as more physical properties matching towards the enamel and the dentin, which are the deeper layers of the tooth itself. In 1930s, Bowen, one of our pioneers of dental resin inventor, has introduced a composite resins where we take a matrix and add several fillers to that. From that day, it's almost like a century now, the composites have evolved to a very large extent to match the shade, functions in terms of physical properties, chemical properties, and also to larger extent to match the enamel itself. On the context of restoring the function, what do we do? How exactly we do the filling? When the tooth is destroyed or destructed or lost its structure because of a decaying process, what we call as the dental caries, the first thing what we do is we use a high-speed drills so that the patient is very comfortable while removing this decayed portion, and then we give a specific form to the dental cavity which can accommodate these fillings. Now, once the process is done, we start making the surface a little rougher using a certain organic acid, that is we popularly use orthophosphoric acid. And once the surface roughness has been achieved, we use something called a dentin bonding agents. These dentin bonding agents are made to glue between our restorative material to the tooth structure by means of a chemical to some extent, and also majorly by means of micromechanical methods. Now, once the tooth has been roughened by means of etching process and also bonded with the dentin bonding agents, we start putting different layers of composites. These composites are very interesting materials per se. These materials, they look like a clay. They are available in various shades and also with the different properties. They are available as a high viscous or flowable materials, or a very thick putty-like a material, or sometimes semi-solid sort of a things. We use according to the need of the material, a need of the restorative, the tooth which is undergoing the restoration. Now, once we realize that if the cavity is not all that deep, then we used to use composites which have got a macro fillers. Then we realized that macro fillers may be very rough, and then we started using a midi fillers. Then we realized that okay, why can't we just add up all the things, and we now at present we are very comfortable with a nano-filled hybrid particulates. The benefit of these particulates are one, they are super polishable, high density fillers can be added, and the third thing is they match the physical properties almost equivalent to our enamel. Once this material has been sculpted into place, once the shape has been given, then we harden the material by using a visible range ultraviolet light. Somewhere between 480 to 420 to 480 nanometers of visible range. These are not ultraviolet lights, they are visible range of that spectrum. When we use this material, the material starts getting polymerized. This curing lights, the lights what we use for a curing purpose is also very interesting. At some point, we used to cure them for several seconds, several minutes in fact. Now, we cure them with a high intensity a curing gun, probably around 5 to 10 seconds, provided that provides at least a 2500 lumens of intensity. Once we cure this material gets as hard as enamel itself. Then comes the interesting part, that is we ask the patient to bite and check for the occlusion. What is occlusion? Occlusion is basically when you close your mouth, it should feel like as if all the teeth are in contact. It should not be like only that tooth which has undergone a filling or a restoration shouldn't feel it is high, or it shouldn't feel only that tooth is in contact, the other teeth are not in contact. Then something is wrong. The patient will have to go through hell if that happens. We make sure we trace those points, we call them as high points, and we grind them selectively so that it matches with the opposing tooth, so that when the patient bites, when the patient brings upper and lower tooth into the contact, they feel very comfortable. In the deeper cavities, probably we might have to give us a different biocompatible layers using a biocompatible materials ranging from mineral trioxide aggregates, biodentin, or maybe a simple calcium hydroxide, and there are various types of materials available for that. Once the tooth has been restored, the beauty of these composites are we don't generally give any instructions. That is like the tooth is ready to take a function in all the forms. You go, you chew, you do whatever you want. There are no restrictions. But at some point, in dentistry, we used to give a lot of instructions. Don't chew that, don't do this, don't do this, so that sort of a thing. But no more such instructions. If the material selection is not good, if the curing is not correct, if the bonding is not applied properly, if the tooth etching part is not done properly, if the layering is not cured properly, everything has its own repercussions on the longevity of the restoration. Hence, what we do a very simple thing. We follow very meticulously each step the way it is supposed to be done or the way it has been explained in our literature. We constantly keep looking for very changes in the product evolution, and we adapt them so that the patient gets the best of the best material benefits as well as the treatment protocols. Hence, at present, most of the time when we restore the tooth, even the other dentists fail to see or fail to recognize that tooth has been restored. We can go to that level of aesthetics. Nobody can even make out that the tooth had a decay and that has been restored. That is the present scenario of the dental filling. They are very safe, very predictable, and very, very advanced method of restoring the tooth.